Hello, friends. Good evening. So, again, welcome everyone to this session where we are going to have a discussion on how we are going to take it ahead from here. And all of you would have been waiting for this. The choice filling, the last date is for tomorrow. So this is from last year, this presentation, and I had asked a few of you to fill up. I have not received too many responses, so I'm just going with this for now. And we'll take it up, and if some more information comes, I'll share it with you guys. But this is pretty recent information that we have. There are a few more seats which are added, and essentially some few common queries is what I'm going to address first, and then we'll go on to the specific queries that we are going to have. Now, one common question that came up time and again in the various discussion was whether to take up MCH oncology or to do, DNB in surgical oncology. This was one question that came up time and again in the this one. As far as MCH versus DNB is concerned, when you come outside and you start practicing, there is going to be no major difference between doing an MCH or doing a DNB. Like anything, the training is what matters, and where you do it to some extent it matters, but then it is up to you to learn whatever knowledge you can from whichever center you're doing it, get the best of it, and then to come out. Okay, so that is the first thing. And where it may make a difference is DNB when you do, and you're going to get to a place where you're going to be in a educational institution. Like suppose you want to join as an assistant professor in a medical college setup, or in what we have as DME in Tamil Nadu, like Department of Medical Education in Tamil Nadu. There, I believe in DRNB when you finish, you need to have an extra year of teaching experience, and beyond that the thing is going to be the same. So if at all there is a difference, it is going to be for probably 1 year of teaching experience you will need to do. But then in whichever center you're working, if it is going to be a teaching institute, that experience you're going to gain, and that is all the difference. In clinical practice, in private practice, as we look at it, nobody looks at whether you have a DNB or whether you have an MCH. Nothing really matters. Practically speaking, all they look at it is whether you have gotten the degree which can be registered with the respective medical council wherever you're going to practice. Like suppose you're going to practice in the state of Maharashtra, then you need to be able to register with the Maharashtra Medical Council. Vice versa for either Telangana or Andhra Pradesh or Tamil Nadu or Kerala or UP or Bihar or Delhi, wherever it is, you should be able to register with the particular place where you're going to practice. And once you are able to do that, it doesn't matter whether you're doing your DRNB or whether you're doing your MCH, there is no difference. The next question that comes is, okay, we have heard that the pass percentage as far as DNB is concerned is pretty low in many places. So is there any truth in the matter? Here again, is where there will be a slight difference, because most places where you have an MCH in any government-based institute, what will happen is, like many of you who would have done your MS in many places, you will have a facility where you will be running the OPD completely by yourself. More often than not, it is going to be the people who are doing the internship, right from first year, second year, or third year PG, who will be running the outpatient department. They will be giving all the investigations as OPD, or if the patient is admitted in the ward also, you will be doing the entire work of the history, the physical, the basic investigations, the PET CT or whatever. Everything is going to be done by you guys as postgraduates. If that happens, then you are very well versed with what needs to be done for the workup of a patient. So when you go for your MCH or your DRNB examinations, what is essentially going to happen is, in the final exam, you're going to have a clinical case presentation. Now, I know that DRNB pattern says that there is equal weightage for 4 cases or something like that is the pattern, but practically what actually happens is examiners tend to still look at it as a long case and a short case kind of scenario. So when you do that, they will have usually an abdomen as a long case, and the other things will be like head and neck or breast or soft tissue sarcoma or penile carcinoma, something like this will be likely to be the short case. They will have 3 or 4 short cases which will be lined up in whichever institute you do. So when you go there, it will be just like your MS examination, or basically your postgraduate examination. What pattern is there? The same pattern will be there. You will go, you will see the patient, you will examine them, you will take the history, you will write the case sheet, and then you will present it to the examiners. So unless you have been doing it on a regular basis for about 4 or 5 years, I mean, for at least 2 3 years in your period of training, what is going to happen is you're going to struggle when you go for the exams, and this makes a difference when you actually appear for the exams. When I went for DNB, I did it from GCRI. They had no clue, and again, the examiners will not have any clue as to whether you are a primary DNB candidate or you have done your MCH and then you're coming to write your DRNB. They have no clue. They sometimes ask you whether you are like that, or if not, they don't even ask that question. They are not supposed to actually ask. They're just going to assess. So they don't know whether you are a primary or a secondary DNB candidate. They are going to assess on how you're going to do it. That's it. So it ultimately boils down to how you have done your DRNB, if at all you're doing it. So for example, if you take up DNB institutes, if I take up the list, if you look at it on the screen, let's say for example we have Mahatma Gandhi Vizag in the list as the first one. Now MG Vizag is a great institute where you have good academics, there is a wide exposure to OP basis and to all the academics and everything. Kachar is going to be run by essentially only the PGs who are going to be there, and Mahavir Cancer Center, Bihar, I think it is, there is some doubt as to whether it is there this time or not, but in general from Mahavir also you get like basically you have a very good exposure to all cases, you will be doing the workup yourself and all that. So when such things are happening, then essentially what happens is you are going to have the entire OPD in your hand, and so your exposure is going to be pretty good. Same thing applies to R&R Delhi or to Rajiv Gandhi, or for that matter, like some other centers like let's say Manipal Bangalore is reasonably good with that. Currently with Aster now, previously it used to be Dr. Somashekar who was there. Now he has gone to Aster in Bangalore, so that is where the thing is. Manipal also has another, this one Dr. Shoaib Zaidi is there, so it is still good. And if you take up Malabar Kannur or MBR Calicut, these are some institutes where I know firsthand that the OP is going to be handled by you guys. So as long as the OPD and the workup is going to be done by you guys, it doesn't matter whether you have done a DRNB or whether you're going to do a super specialty in as an MCH. It doesn't matter, because you are going to have the entire workup in your hand, and that will prepare you for writing the examinations. So the next question will come is, so then what happens? Let's say for example, Apollo Chennai is one place where you will have an extensive exposure. All surgical oncology cases you will be able to see and witness firsthand. You will be most likely the first assistant, if not you will be the second assistant. So you will be handling every case, including let it be head and neck, let it be breast, let it be conservation, sentinel lymph nodes, let it be limb salvage surgeries, let it be your HIPEC, laparoscopy and robotic work, whatever is there, you will be able to do you'll be able to see every case. But the major problem with Apollo Chennai, I will say, is because I was a consultant there, I knew what happens. So the consultants are going to see the patients in the OPD completely. So for 3 years, you will have almost no exposure to seeing patients directly in the OPD or evaluating them first. And let's say there is a patient for I have a patient, for example, who is scheduled for an endometrial cancer resection on Wednesday. So this is a lady who has got a endometrial mass and with a parietic nodal mass and everything. All the evaluation and workup is complete. But let's say that one of you guys is working with me as a postgraduate. Then what will happen is, this patient, when is the patient going to get admitted? This patient is getting admitted tomorrow evening at 6 o'clock. The surgery is planned for Wednesday. Patient is getting admitted tomorrow evening at say around 6:30. They will get admitted whenever the beds get free. That is a typical scenario in many private hospitals. Only when the bed gets free, the next patient will get admitted after cleaning this one, some insurance process, billing process. There is so many other things that will happen. It is not like a government hospital where you give a chit and immediately the patient gets admitted. Here, there are so many other things to take care. So the patient will get admitted late in the evening, and so what is the chance that you as a postgraduate will have to see the patient? Very little. You might just see them towards the end of the day, because in many cases the OT will start quite early in the morning at 8:30. You will come, you will start, you will have to take a consent, you will have to prepare the patient, everything will happen. You will be in the OT from morning till evening. You will be doing that, taking ward rounds, taking this one, everything you will do. So by late evening, when you actually go, you will not have time to see the patient or to work them up. So a suggestion for those of you who may get into one of these institutes where you do not have an OP exposure is, you make it a point, because there are totally around somewhere around 250 300 seats which are available this time, and for those seats what is going to happen is you will get into a lot of DNB institutes. So if you can get into a DNB institute with a good exposure, fine. If you are not able to, make it a point to have one case every day, so that you can see the patient yourself and you can evaluate as if it is a fresh patient. Don't look at the reports, don't look at the investigations, don't ask for the history, don't ask for the plan, nothing. You just go and see the patient like you are seeing it for the first time in the OPD. Go and ask the patient right from history, physical, everything you do completely, go through the reports and then find out. Just think of what are the investigations you will order. Let's say I will do a CECT of the abdomen and pelvis, I will do a CT chest, I will do a bone scan, I will do serum PSA, I will do a CA125, whatever is there, just list it out mentally or write it down in a chit of paper, then look at the reports which are going to be there. That way you will be able to have the training which is needed. For those of you who are not able to get into an institute which has got exposure, this is the way you will have to do it. And so that training, if you do it on a routine basis, then yes, you will be able to do pretty good uh, whichever institute you get into. So this, I will put this debate to rest once and for all. It doesn't matter whether you do MCH or whether you do DRNB. In fact, doing a DRNB from from an institute where you have a very good exposure is going to be far better than doing an MCH from some of the private institutes where you may not have any exposure, where you will be literally spending a bomb and everything. So that is the thing that is going to be here. So That is going to be the initial thing. Now, next question is, what are the things to look for whichever places you are going to go to? One is, as I already told you, the OPD exposure needs to be good. So next thing is, many of you will think that, cutting is the main thing that will matter. As far as surgeons are concerned, we all think, we all want to cut. That is the reason why we all became surgeons in the first place. But cutting is there, it is important. Personally, when you do the cases, it is good. It is always better. You will have more confidence when you go. You will be able to do it faster. The steps will be very familiar to you. All that is there. But then I just want you to ask yourselves a question on how many major cases you would have done even as a, as a resident during your MS period. See, most of us would get to do, an appendix, a chole, a hernia, hydrocele, some bit of major cases, maybe a truncal vateotomy, gastrojejunostomy, perforations, and bowel resections, as far as it is coming as an emergency. All this is something that most of us would have done as postgraduates, because emergency cases will be handling all this. But elective cases, when you look at it, other than the basics, you may do 2 or 3 cases like that, depending on the institute. It may be as low as just doing one case. You may just do one colectomy, one major thyroid resection, one mastectomy, one gastrectomy. Like this is what is likely to be there, because in many places what is happening now is, even in government institutes, it's like the kind of assistants who are coming are also young. Like these are all guys who have just passed out and who want to have some more hands-on cutting, so they may be doing it more than the actual PGs who are going to be posted there. I'm sure some of you here at least would have gone through that kind of experience. So what I want you to understand is, all of us here are already surgeons. All of us are familiar. You are all consultants already. The fact that you have written these exams means that you've all done your MS or your DNB in surgery, and you're all consultants already. You are handling cases on your own to start with. So what does that tell you? You can assess and you can do it. So why do a super specialty? Because you want to know a little bit more about that specialty, and you want to focus on one area, and you want to take it ahead, and you have to build it up. That is the reason why we choose a specialty. So other than cutting, there are a lot of other important factors that we need to look at whenever we are talking about any institute, of which the first thing I would say is the exposure to the cases. Even more than the cutting part of thing is, what kind of exposure do you have in a particular department? Like, for example, I gave the example of Apollo Hospitals in Chennai, which has got a DNB program which is running. There, the exposure is perfect. It's pakka. You can take any case you throw at me, every case you will have that. Every department you have it here. You have skull-based surgery, you have robotics, you have lap surgeries, you have GI, you have head and neck, you have thoracic, you have breast, you have gynae. Whatever you throw, every surgery you would have assisted by the time you finish your DNB program here. So is that good enough? Yes, that is one thing that you're looking for, whether it's an MCH or a DNB. The first thing is OP exposure. The second thing is going to be your exposure to all varieties. In this, again, there are some areas which should definitely have a good exposure. When you come out, the bread and butter in surgical oncology is going to be head and neck, breast, gynec, and GI. These are the 4 major things that will form the basis of all your cases that you do. Majority of the cases, I'll say like around 70-80% of the cases are going to be in this group. So it is going to be head and neck, it is going to be GIT, it is going to be your gynae, and then it is going to be your breast. These are the 4 things that will be very, very essential for you to do. And in this, breast surgeries are pretty easy to do. Breast surgeries, you can learn. Many of you might have done mastectomies even during your post-graduation. And as far as any MCH or DRNB candidate is concerned, most institutes will have a good exposure to breast. So the difference will come in exposure to having, let's say, sentinel lymph node biopsies, or you may want to do a few flaps. You may want to do an LD flap, or you want to do a LICAP or an ICAP flap, or other things and all this. So this, if you have the exposure, it is good. But then even if you don't have it, it doesn't matter to a huge extent, because these are pretty simple to learn. Even when you come outside, it doesn't matter. So breast surgery as a whole, you need to have a decent exposure. A reasonable caseload is there, then it is pretty simple for you to learn that during your posting. So that is not of concern. So then comes your GIT, gynae, and your head and neck. So in this, again, GIT, most of us are already familiar with as general surgeons. Most of us have gone through it. Abdomen is a very familiar area for most of us. We would have done or assisted in gastrectomies, in colectomies, in LARs, in APRs. All this is something that many of us would have done or assisted in whichever place we did our MS or MCH or what, I mean, MS or DNB. It doesn't matter. All of us, the abdomen is basically a familiar territory. We are just hoping to advance the knowledge that we have here. And here again, many institutes will have a decent degree of GIT exposure. Of course, in some institutes, it's a little less, but abdomen in general is an area which many of us do need to worry about. So here the specialized areas will actually come among the abdominal cases will be in esophageal surgeries, which not many general surgery units do. So one is the esophageal surgeries, which will be done done by sometimes by thoracic units or by surgical gastroenterology only. It will not be done by general surgery. So that is one. Second is going to be HPB, hepatico-pancreatico-biliary surgeries, which are again many a time going to be handled by the gastro department or by the hepatic team or a transplant team, whichever may be in various hospitals. So this is one area you have to look at whether you are getting enough number of cases. But let me tell you again, even here, the number of cases that you get as far as hepatico-pancreatico-biliary is concerned, at least as far as South India is concerned, is not a very huge number. Yes, it does help because, Whipples or doing a radical cholecystectomy or a hepatectomy, all this requires a lot of planning, lot of exposure is needed. So that is one area where you wish for some cases to be there in this one. But even if you don't have, you can always go outside and start learning a little bit. You can work in a unit and then you can get trained and you can come home. So next is the GIT thing. So breast is over, GIT is over. The problem happens in many places, especially in today's world, in terms of gynae oncology, and the next one is head and neck. Now, head and neck again is the bread and butter across India. Whichever place you are doing, head and neck forms a major chunk of resections as far as surgical oncology is concerned. But head and neck, by and large, many institutes have a good program because it is the number 2 cancer in India right now among the males. So you have quite a wide variety of head and neck cases. So the basic cases with regard to either tongue or buccal mucosa or cheek or composite resection, PMMC flaps, all this is something that many of you will see or assess during your period, and many of you are likely to do a lot, huge numbers as well as far as head and neck is concerned. The problem now that happens is some institutes where you have a concomitant course in MCH in head and neck oncology. When you have that kind of course or you have major fellowships that happen, like for example, what is happening at Tata, your exposure to head and neck is far less. Though it is still the number 1 institute in my list, I will still say the exposure in head and neck in Tata has come down drastically. This is something which the faculty or the alumni who are the high-end alumni at Tata themselves have told me that the number of cases that the residents are doing nowadays has come down. Why? Because it's a simple thing. Imagine you're working in a unit where there is a resident who is going to stay with the chief for the next 3 years, and then you have a person who comes in for about 3 to 4 months as a posting. So whom do you think the chief is going to turn to? They are going to turn to the person who's going to be with them for 3 years, and that is exactly what is happening. You get an MCH head and neck oncologist who's going to work in the same time as you are doing. At the same time, you go for rotation for about 3 to 4 months. So the number of cases you get to do is going to be limited, or you are going to have more competition for it from those fellows. And that is where the difference is going to come in. So yes, the number of cases have come down, but still any good institute, when you do head and neck surgery, is not really rocket science. Many of you, once you get familiar with it, it is not going to be very difficult for you at all. It is a pretty simple area to master, except for the really high end, like you want to do an ITF clearance or skull based surgeries and all that. And that, even if you finish your surgical oncology, you will still need a further exposure for 1 year or 2 years at a specialized center before you can master the art of skull based surgery or something like that. For that, you need to have really specialized exposure. So don't worry. Just look at whether there is a decent head and neck caseload there. This is one. Next fact comes in gynae oncology, and this is actually a problem for many of us because head and neck exposure will be there in every unit. But gynae oncology, now what is happening is, previously every gynecologist used to refer the case directly to surgical oncology. They may do a few endometrium, which they will do a hysterectomy and leave it at that, or they may do a few simple ovarian cancers. Now, because gynae oncology has come up in a big way in many centers, many of the cases are going towards the gynae oncologist. The simple cases are going towards them. That is a problem. And so we as residents will have a problem because, when we do, we will initially start off with the simple cases. So your chances will come down. So in many institutes, what is happening is the complex gynae cases are coming to you. So still you will be able to do hysterectomies or pelvic excentrations or, pelvic peritonectomies and major parietic dissections. All this will be happening in and around you in the unit, and you will be exposed to that. But, it is always easier to learn from a simple hysterectomy because most of us are surgeons. Many of us will not have an exposure to gynae oncology or gynecology in general. Many of us will not even be aware. I was not aware of how to do a hysterectomy before I actually started my practice in surgical oncology. There are a few surgeons who also have a regular practice in surgical, in gynecology, but many of us will be feeling it is unfamiliar. Let me tell you though that, hysterectomy as a surgery is not a very big or a very difficult surgery or anything like that. So once you're familiar with the pelvic anatomy, doing doing your low anterior resections, doing your radical cystectomies and things like that, then the anatomy of doing a radical hysterectomy is not that difficult. Essentially, you have to look at only the bladder and the ureter. These are the major two structures that you will need to worry about. The rectum will usually not come in the way. So these are the two things, the bladder and the ureter, you will need to dissect it out. So once you learn the technique, and that is usually feasible in many cases, because you can identify when you're doing a pelvic dissection, always you will identify the ureters. You just need to trace it down, tie off the vessels, and then do it. Once you have this technique known, then mastering it is not very difficult. So this is a concern that many people have. Just take it outside your mind. It's not that difficult to learn. Of course, when you have a major exposure, it does help. For example, in Adyar, the cutting chances are relatively low when compared to the other institutes. But even here, the best chances are available in breast and gynae. So when I came out, I was already very familiar with doing hysterectomies, and with doing your staging for ovaries and breast cases and all this. I was like, it was never a concern for me. I was more worried about how I will handle major head and neck resections, or will I be able to do it without friends or help or things like that. This is what I was thinking at that point of time when I finished my MCH in surgical oncology. So 4 departments, again I will stress, it is head and neck, it is breast, it is GIT and gynae. These are the 4 major departments. So other than this, what are the other things that you're looking for? Then you're looking for the other subsidiary departments like thoracic, which is growing in importance in today's world. Then you have the hepatico-pancreaticobiliary. Even in GIT, you have to look at HPB separately, how good is the exposure. Then you have your musculoskeletal oncology, which is available only at a few centers. But don't worry, even if you have zero exposure to musculoskeletal oncology, it is still okay, because it forms a very small percentage of the cases that we'll do. What is more important is probably uro-oncology in terms of nephrectomies and things like that, where you need to be able to do that, because in general surgery, again, the exposure to uro-oncology is going to be less. And so nephrectomies or radical cystectomies and things like this, if you have an exposure, it is good. But again, those numbers are pretty low, and many of these cases will anyway end up with urologists. So it is not a major chunk. It may form around 10-15% depending on where you are. And as surgical oncologists, you are expected to know. But it is again not very difficult to understand or to master these techniques, even if you're not having a great exposure, provided you have an exposure in pelvic oncology. So that will happen for all of you whenever you're going to do. So unless there is a very grossly bad review for gynae oncology, it is not going to be a problem for you. You will be able to handle pretty much any case that comes at you. So these are the other departments that will come to you as far as this one is concerned. Now going on to specific institutes. So now till this point, does any of you have any questions? You can put it up in the Q&As and I can answer. Till this point, is these basics clear? What you need to look for? You need to look for specifically these things. The OPD exposure, you should be handling and working up patients as far as possible. If not, you should have a provision for doing it when you go into your DRNB at some private hospitals. Second thing is, you should have a good exposure to these major 4 departments. Additional departments which are available are good. Sorry, I forgot to mention about laparoscopic and robotic surgery. So laparoscopic oncology, again, in today's world, I will consider as an essential thing for most of you to have at least the exposure. I'll be very frank with you. None of you will probably be able to do any laparoscopic hands-on, except in probably, like, for example, in Indo-American, you get a good exposure to laparoscopic surgeries, and many of the residents are allowed to do a part of the thing. So, but in what is more important is, like, you have to have an exposure to laparoscopic surgery. It's not more like you need to actually be able to do it, but you should be able to assist firsthand in doing the laparoscopic surgeries. That you may think, what does it matter? Because I'm not doing it, how does it matter? But then I'll tell you, being a camera person or being the first assistant, both these are the major things that are important in lab surgery. In fact, even more than the assistant, it's actually the camera person who needs to be spot on. So that skill, if you learn during your MCH or your DRNB, then you're pretty much got a good skill. After that, you need to build up your skills in lab surgery, because I don't know how good you are. For me, it was zero exposure to laparoscopy during my MS period, because at that time laparoscopy used to be done by only the senior most assistant or the chief of the unit only will be doing lab cases. Even I'm talking about simple things like lap chole or lap appendix, and the same thing will happen even in gastro also. So after I came out in about 4-5 years, lap had become widespread. It was available at all the centers, even residents in post. I think most of you will be in an era where you would have done laparoscopic surgeries and you would have come out. So that is the way it would have been as far as you are concerned. So I think your exposure to laparoscopy will be reasonable. But that said, I will still say a good exposure to laparoscopic oncology is needed in today's world, because many of the procedures are going to an era where you are going to do it by laparoscopy. Next comes robotics. Is robotics important? Because many places it is coming up. Is it mandatory? I would say it is still an evolving field. yes, there are very clear areas where you have an advantage of robotic surgeries, especially in robotic prostatectomies. But other than that, if you look at it, robotics is still an evolving field, and it is like, minimally invasive. It can be laparoscopy, it can be robotic. There are few areas where robotics gives an enormous advantage, especially where endosuturing is involved. There robotics has a great advantage. And again, where you need to have a kind of like, for example, in the pelvis, when you're doing a low anterior section, you will have a curvature of the rectum like this. You will instrument will go like this, but you cannot bend the instrument like this anteriorly. Whereas in your lab, in your robotic, your instrument will have another degree, so your instrument will be able to bend. You can have the vision and you can do it as well. So that is the way it will be useful for you. Okay, so these are some things that we need to have in mind. So if you have robotic, yes, that is always better. But then uh, it is like, I would put it as, it's a plus minus. If it is good to have, if you have it, take it, give preference to that institute, because many a place where you have a robotic surgical oncology institute, then the institute will be good in other things as well. So if you have it, then you can prefer it. Otherwise it is not mandatory, but lab exposure, I will say, is definitely mandatory, right? So next thing is, some of the questions that have come up is average MCS versus good DNB. I would always say the answer is very clearly going to be a good DNB. When you have a good DNB program, don't hesitate at all. It doesn't matter. As I already said, a good DNB is in any day better than an average MCH. Passing for pro people is not going to be a difference, because if you're going to put in the effort, then it will be pretty good as well. So onco residency who are recent pass outs without SR work experience, it doesn't matter. See, oncology, just remember whatever you have learned in surgery and improvise on that. So that is the ones that you need to look at, and that is the thing that you need to have in mind. So if you have SR experience, it is fine. I, for example, worked initially, I joined urology, and then I was there for some time, and then I came out. I did in a medical college setup where I was working as an assistant professor, and then I came not too much of experience in terms of surgery. We'll be able to do a few cases, but nothing major. Major cases used to come only once in a while, because that was also a new institute kind of thing. So I didn't have a huge experience when I went into surgical oncology. So it is all about putting in the effort wherever you go to learn everything there. Okay, so somebody has asked whether GIT courses go directly to surgical gastro. What is the job opportunity for surgical oncology in metro cities? Yeah, so yeah, this is again one thing that many people are now asking. So you yourself, I mean, I myself told now that about there is something called gynae oncology, there is breast oncology, there is breast surgery courses which are coming, there is head and neck oncology which is coming up. You may get a few other courses like this one. Other than the surgical gastroenterologists, urologists, everybody is putting themselves as surgical, I mean, onco gastrosurgery or onco urology or something like this. All these kind of things are going on. Yes, that is a concern. I am not personally a favorite of subsite specific oncology, except in an institution based setup where you have a large volume, like say you have a Tata or an Adair or a Kidwai or a GCRA, where enough number of cases come, then you can divide it, and then the consultants can take and do it. Then that is fine. But in your private practice, it is going to be a mix of cases that will always come. And a person, let's say you're doing a patient with an ovarian cancer, you need to be aware of how to do a low anterior resection. You cannot at that point of time call the gastroenterologist for doing it. Or let's say you're doing you are an upper GI surgeon. That is the famous word that you will have. Let's say you've got a patient who has got a gastrectomy. Unless you know how to handle the portal triad, you cannot go in and do a dissection in the portal area. And suppose there is an injury, you should be able to handle that. You should be able to handle a liver resection. Suppose there is a metastasis which is sitting there intraoperatively, you shouldn't be waiting for a your liver transplant team or somebody like that to come in and do it. So I would say during your MCH and this one, it is better to get exposed to all the things. So disease management group, this is exactly what I was telling you. I will put it this way: if there is a chance that you will be ending up in major cities, like I'm talking about the major metros like Bombay, Delhi, Calcutta, Bangalore or Hyderabad or something like this, in these areas, because of the corporate setup, it might be better for all of you once you finish to have some more experience in a subspecialty field and to be known for that. Take up one field. By the time you're doing your MCH or your DRNB, you'll know which area interests you and you can build it up and you can do it. So that will bring in more cases, because many hospitals, they will expect a team based approach, or they will want to propose this subsite specific approach. See, for example, in gastro, we all know that across the world, you have upper GI surgeons, you have lower GI or colorectal surgeons, and then you have HPB surgeons, you have separate hepatic surgeons, pancreatic surgeons, all this is there. But nobody asks a DNB, a candidate in SGE, whether he's specialized in upper GI, lower GI, or hepatopancreatic or biliary or a transplant. Nobody asks all this. Transplant is, but the rest of the thing, they don't ask anything whether they have any specialized training. This is something which has come about in the recent times. But I will say, except in the core cities where, like, you are in the heart of Chennai, let us say, there you may have a need in the future, especially by the time you guys graduate and come out and then start practicing. There might be a need to specialize yourself in one field. So I will request all of you, first of all, to think. There are many who ask me, like, can I take it up near a place where I am sitting, or near my place, or to look at the bond or look at the fees and all that. See, always remember, take the best institute which is going to be there available in and around your rank. Don't bother. Even if you have the last possible rank which is possible, mark Tata first. You never know, you may get it for some quirk of it. Sometimes it might happen. I know once it happened at RCC. There were multiple waiting list candidates. That time it was a separate exam, and that particular day somebody had to go and join, and only one candidate was available near the site, and that's why she got the rank, though she was somewhere around 5 or 6 in the waiting list. It happened. So nobody knows how things will pan out. So just have it, when you are marking it, mark the best possible course which is there, and in and around your list you prepare, in and around your rank, based on the previous allotment list, you prepare a list of institutes in the order. That is the only thing that I can tell you with regard to that. Okay. So to join DNB Onco, leaving a government job is completely fine, no issues at all. Doing a DRNB is as good as doing this one. It's not government setup or private setup. It is only teaching experience. If you're going to be in the DMS side of things, like the Directorate of Medical Services, as we call, like non-medical college associated hospitals, your DRNB is equal to MCH as far as guidelines go. So that should be okay. So private MCH with less exposure, expect to learn the majority during SR ship is difficult, because there is one problem with that approach currently, because here what happens is, previously a lot of institutes were offering this SR-ship. Now there have been just an increase in the number of seats has happened. Every year there are lots of seats which are increasing. So when that happens, it is going to be difficult for you people to get a good SR-ship pose, and then to finish, and then to train again, and then to come. It's difficult. So do it at one shot wherever you're doing it, rather than thinking that it is going to happen later. I will have time to do it later on. Okay, so that is one thing. So before going into the specifics, I will just, sorry, before going into other questions, I'll take a brief time to just discuss this Excel sheet which I have put here. So let's talk about the various institutes which are here. So SWIMS, this is Venkateshwara Institute of Medical Sciences, which is there in Tirupati, where you have a decent exposure, except in GIT and thoracics, where the number of cases are less, but surgical exposure is good. And basically I will probably share this PowerPoint. I don't think we have time to discuss. I mean, rather the time, I wouldn't say, whatever is there comprehensively, I've tried to include it here, and I am updating the list as well. Actually, I've shared it with a lot of people, and I've given access to many of them. I'll require your help, because this is a laborious task, going through almost, like 150 institutes and places, and to find out who's having what and getting a contact and everything. So I've tried to do it in many places, and I will try to update the list, and I'll put it up by tomorrow morning itself. Whatever has come tonight, I will just share it in the group as well. So if any particular questions are there, I will address them now, whatever is put up in the Q&A task now. Okay. So next one is SMS Jaipur. Somebody, I'll just go back a little. um, yeah. Yeah. Rajiv Gandhi Cancer Institute is a great center in Delhi. No need to worry about it. DRNB, if you're getting straight away, take it. No issues at all. You can directly take. Same thing applies to Mahavir Cancer Sansthan in Jaipur as well. Both of them are pretty good institutes. At Rajiv Gandhi, you have pretty much exposure to all the fields, including robotic surgery and everything. Hands-on, you will get a reasonable degree. You will do part of the cases and all that. Mahavir Cancer Sansthan, again, is a great place for doing basic cases. Everything, you get a pretty good exposure. All that is going to be there. That is not an issue at all in with this one. But then academics, I believe, are slightly on the lower side, so it may be a little bit of kind of unsupervised cutting which is going to be there. Okay. And SMS Jaipur, again, you will get a lot of cutting, because it's a pretty good institute. In general, remember guys, where you do not have a center of, like, a regional cancer center kind of thing, where a hospital based, like SMS is generally, if you think of SMS as a general hospital, if you have good cases, again the same thing will filter down to oncology as well. You will have a pretty good exposure to almost basic varieties. All the cases you will get, like in that area, if you take up GIT and head and neck, and to some extent gynae, all this will keep coming for you. That's not a problem. KGMU, somebody had already posted in the group. It's actually a good place. You will get a pretty good exposure to almost everything. thing. I think things which are not available there are minimally invasive is a little less. Only now it is starting to build up there, and GIT exposure and thoracic exposure are little on the lower side, because those things go to other institute, and then the SGPJ is also there to compete. So because of that, GI cases are slightly, it is like kind of like the tussle of war will be going on. So just like what happens at PGI and JIPMER and all those places where you have a specialty institute in gastro, there the number of cases which will be like difficult to do. Okay, someone has asked whether I tried gastro all these years. I got a decent rank. I like onco surgery, government job with a very good pay. What is your opinion? Always remember, my friend, do a specialization. In today's world, even if you have a job, your government job is still going to be there. Don't need to leave it. You can take leave or permission. I'm sure that is available with all the government things. So you can take a leave or some kind of thing, and then you can get your specialization and come back. Try to take it in your own place so that you will have a bit of practice as well. So that is what I would say. Okay, so corporate hospital with all tech or trust hospital with basic exposure, this is something where I will say this depends on your exposure in MS. So if you have had a pretty good cutting in your basic surgical skills and all that is mastered, then I will say go to a corporate hospital where all technology is available, so that you get to learn the new techniques and observe. And remember, my friends, cutting is only important to an extent. As a first assistant, whether you are able to assist cases, whether you are having exposure, I will tell again, that is the most important thing. Once you come out, that is going to, you have to handle all patients, you have to handle all complications. So the exposure matters much more than this one. So in this scenario, trust to assess corporate hospital, I will say if you have already have a good basic exposure, choose the corporate hospital. If you feel your surgical skills and your hands are pretty rudimentary, or you would like to have more exposure, in such a scenario, I will say it is better to go with the one where you are going to get more of hands-on job opportunities. I will tell you, we all know that the cancer incidence is growing by leaps and bounds across the world. Forget India, it's growing across the world. And even though there is a lot of medication, there are a lot of non-operative managements, interventions are going on, any of these things are happening, still I will say there is going to be enough job for all of us. The question is going to be where the job opportunities are going to be. This, I think, will get more diffuse and go more towards the periphery rather than inside the cities. Even inside the cities, the opportunities will be there, but this is again a broad based question which is going to be there for all specialties and for the field of medicine as a whole. Now, Dr. Vijay Kumar, who was discussing with the policymakers and everybody, he asked this particular thing: why you are increasing the onco seats? So not just onco, with every specialty, why are you increasing the DRNB seats and the MCH seats by a huge number? The answer which I'm talking about people in high levels of government, which they gave him was like, no matter how much we try, people are not moving to the periphery or towards the tier 2 cities or whatever to start their practice. So the only way to drive out people towards the periphery, drive doctors towards the periphery, is to create competition. So if you have too much of competition which is happening in the main cities, then automatically people will start going towards the periphery looking for more opportunities there. And that is exactly what we are doing. That is what they've said, which from a policymaker's point of view makes a lot of sense, though it is completely unfavorable to us. From a policymaker's point of view, that is completely true. See, if you find that there are too many surgical oncologists in Chennai, they will go towards somewhere in the periphery and start their practice, which means that healthcare is going to be better covered, and that is what will happen. And remember, my friends, this is again something which all of us will carry. Even here, I will tell you, I'm sure that most of you who have come here only because you want to take up oncology. Look at other specialties also. Have a second option in mind. This is something which I've told many other people who wanted to get in, because we all have this thing: why did I choose surgical oncology? That is a question that you have to answer yourself. Just don't take it for the glamour or for the fact that it is something that you can do from head to foot. I want to do a masterful resection. Yes, those are all important things, but then ask yourself whether you're looking at the other specialties, because our exposure to other specialties is far less when you compare gastro and onco. Gastro, abdomen, so we are all very familiar, we want to do that. Same thing applies to onco, because chunk of work still happens in the abdomen, and we all like the work which is done in onco, precise dissections, a lot of planes and everything. So many of us will like oncology, and it's again head to foot. So that is the reason why many of us choose it. Let's say you have an option to take up head and neck oncology, it may be a good option. You're straight away doing an in specialty. You may have more opportunities to get in where you may be more welcome. You may take a vascular surgery, not there are only about 100 200 vascular surgeons across India. You may ask what is the role, but then vascular surgery will grow more in the years to come. And vascular surgery is one specialty where endovascular interventions are also done by the vascular surgeons. Unlike us, like for example, cardiology and cardiothoracic are always at loggerheads. There is no in between. Like stenting is done by the cardiology team, and then if not, the bypass is done by the cardiothoracic. Valve replacement, again, many of them are doing a TAVR, like all those other things have come up. So the opportunities for GI, I mean gas, and for CTVS is reducing. But then on the other hand, thoracic surgeries are improving. Lot more lung surgeries are getting done. You also have something like ECMOs which are coming up, transplants are coming up. So these are good opportunities in other fields as well. Same way in vascular, every place your work can be done only by another vascular surgeon. Nobody else can do that work. If there is a vessel which is ruptured or injured or whatever, only another vascular surgeon can do a reasonably good job, or somebody like a transplant surgeon who's trained to do that. If you are in a lurch, many times as surgical oncologists, we have also called, I mean, we are reasonably okay. Once we learn, then we'll start doing it. But then many a time it will be you who will be doing it as a vascular surgeon. So these are some fields. Look for unique fields. Neurosurgery, your only competition is going to be another neurosurgeon. So have these at the back of your mind. This is only for people who have not decided on surgical oncology, who think that that has got a lot of scope, and because I like to do everything. That attitude, if you have, just rethink, think through that, and then get into the field. So there is nothing against surgical oncology. There is still a lot of work for surgical oncologists. Whoever is going to come out, enough number of cases are going to come in the years to come. And again, building a team, having good relationships with people, with referral centers, all these soft skills also matter a lot when you come outside and you start your practice. So it is not just about which institute you do, having an MCH, having a DRNB. That is the first step. But beyond that, there are so many other soft skills which you will understand as you start your practice, which are more important, which will be there always. So thoughts on Homi Baba Varanasi? It's a great institute. It's one of the recently launched institutes. Good exposure is there to almost all the basic surgical cases. So definitely you can take it. So average surgical oncology versus government plastic surgery, what to choose? It's not about government, it's about a good institute plastic surgery. As I said, plastic is again another huge area where a lot of work can be done. So you can do cosmetic surgery, you can do implants, you can do hand surgery, you can just do facial reconstructions, you can do so many this one plastic surgery. In fact, free flaps itself is an area where you have a good demand for plastic surgeons wherever you go. Not too many plastic surgeons are actually doing free flap. So you just do your free flap and get into an onco institute, you have it made for you. So that work cannot be done by anybody else. It's, unless you have a surgical oncologist who's getting trained in a microvascular work, you cannot, and nobody else can do it. So average surgical oncology versus this one, this is where you will have to make a choice on which one you like the most and instinctively go for it. So Aster, 3 seats under Dr. Somashekar, but new institute. I think you can directly take it because Dr. Somu is a person whom most of the cases come for Dr. Somashekar. So already Aster is taking off in a big way, and they are getting robotics as well and everything. So it will be as good as what was Manipal before. And Manipal is also going to remain as another institute, which is good for you because Dr. Shoaib Zaidi is still there, and you'll get a pretty decent exposure of cases in both the places. So both places you can take. Bharat Cancer Center, not too familiar. HCG Ahmedabad is a good enough place. See, remember, for every private institute, many of the well-known private institutes doing a DRNB will make good sense, provided you have exposure in your basic surgical skills in your MS training. So if you have had basic, like something similar to what I told about Apollo. So if you have done a good training before and then you come to Apollo and then you train, doing a DRNB is a great thing because you're going to get exposed to everything. You do get to do, unlike what many people think, even at Apollo, you do get to do hands-on a few cases at Apollo Chennai also. I know this firsthand from the postgraduates who have done it there. So you will get cases which can be done there. Basic, some cases will be there. But you have to remember that, of course, those are private patients where hands-on will be mostly by the consultants, and you will be just doing the closure or the opening or helping out mainly with that one. So you will have to come out and have a lot more hands-on rather than this one. Okay, so Dr. Sandeep Nayak is a great surgeon, and he has got a lot of exposure in minimally invasive, and he's getting into robotics as well. So Fortis Banerghatta will be a good place. You have a decent exposure also there. So there is a person who has messaged between SMS Jaipur, KGMC Lucknow, and Rajiv Gandhi, considering a 2M. This one I think is a pretty clear thing. I think you can choose, if you do not bother about the bond, then you go for KGMC probably as the first choice. But Rajiv Gandhi also is likely to be, I mean, it's one of the top institutes where you can do. Rajiv Gandhi is a great place to do your DRNB. This one who's going to do DRNB at Rajiv Gandhi, you will be doing pretty well. You get a great exposure there, not a problem at all. Second, in this three choices, I will probably say Rajiv Gandhi is first, KGMCU is second, and SMS Jaipur is the third one, considering the bond options as well. Dharmashila is again a good center where you have a pretty decent exposure to a lot of cases, and everything is going to be this one. Number of seats at Tata, see, this things, with regard to whether something like what is going to happen at a particular center regarding the number of seats, it's never going to get cleared, because we have a very poor NMC and NB. Both of these are the departments that coordinate and get the number of seats and everything, and this is going to be always something which is open to discussion kind of thing. But in general, Tata, if you do, it is not going to be a huge thing, so I think you can take a chance and take it up at Tata. Now, as regards Max Saket, Max BL Kapoor, all these are good institutes. I think Dr. Hari Chaturvedi is heading the team at BL Kapoor. So BL Kapoor is a good place to work. Dinanath Mangeshkar, I don't have any particular this thing. If I'm not wrong, I didn't get even the last time. So I would request one of you to actually, if I put it up in the group, it will be there. Otherwise, it may not be there. I will not be aware of what is happening. So yeah, so those are the questions which have come up in the group so far. Any other questions that have come? Anything which I have missed? I hope I have answered all the questions. Yeah, Tangam. Tangam Hospital is a great center. Hands down, take it. Don't worry about it at all. Tangam is, run by almost everybody there. The faculty are all from Tata, and I know them all personally. They're all pretty nice people as well. So hands down, you can take it. It'll be good in everything. They have everything there. They have thoracic, they have robots, they have laparoscopy, they have paper publications, they have conferences, everything. Whatever you think of it, you can take it. So Tangam is a great center. No need to worry about it at all. In general, I believe the DNB program is going to be an easier choice to make in many cases compared to an MCH program. So DNB, when you look at it, because the fee structure is going to be pretty similar across India, and the payment is going to be on par with the MCH, whichever is going to happen in that place. So the fees and this one is going to get sorted out, and there is going to be no bond also once you finish in many cases where you're doing a DNB. So this being the case, I think you can definitely go for many of you can definitely go ahead and you can take the option of DRNB. If you feel the institute is good, don't worry too much about it. You can go ahead and you can take it. HCG Vadodara, no, I'm sorry, I don't have a really great option as this one. So as far as Nizams is concerned, it's got a fairly good exposure. The only thing is, I think they don't have robotics, and laparoscopic work is. Let me check it. I've put it up here. Laparoscopic load is low, but other than that, basic cases is pretty good. This one. BHU. Now, BHU is an interesting case. You will have an excellent exposure, but the only problem with BHU is you are running the entire oncology unit, inclusive of medical oncology. So you will spend a lot of time giving chemotherapy, managing leukemias, knowing the regimens. It is a pretty heavy department to work for as far as BHU is going to be concerned. So whether you want to take it, yes, it is pretty okay. It's one of the oldest institutes. It's a government institute, so the caseload, reasonable hands-on, all that will be there, but it will be heavy work for you. The part where you are giving chemotherapy, whether you take it as an advantage or a disadvantage, is entirely up to you. Suppose you want to go to the periphery, many surgical oncologists are now doing the chemotherapy part also by themselves, or just have somebody naam ke vaste, and then they do it, because there is a lot of money which is to be made in all these recent immunotherapy or chemotherapy or whatever. So if you are having your own center or starting your own center or something like that, please do consider going to BHU, because you will have exposure to everything. So it is like that, and surgical exposure is also pretty good. There is no doubt about that. So that will also be pretty good. B Barua is an excellent center. Hands down, you can take it. No worries at all with regard to B Barua Cancer Center. It's one of the best places. I know some of the faculty. One of them is an alumnus of Adyar who has gone there. I know two other people who work there. That's a great center to work with. And B Barua is one of the referral centers for entire Northeast, including Assam, where a lot of cancer cases do come. So there you can definitely do surgical oncology, no doubt about it. I know one of the residents who finished there, they are getting into HIPEC, they are getting into laparoscopic oncology. So that is a good institute for all of you to take. And choice between Aurobindo, MGM Jaipur, Vaidehi, Yenapoya. Order is slightly difficult here. See, again, one thing I will tell you here, if you're seriously getting into a course where the cost of the course is going to run into, let's say, 50 lakhs, 60 lakhs, or 1 crore like that, seriously have a rethink on whether you need to do it. Of course, if you're completely loaded with money, I'm talking about the MCH courses, not DNB. DNB, the main advantage is the fees and the remuneration which you're going to get is going to be fairly okay at any DNB center. So DNB, don't worry, if your choice is just to do surgical oncology, if you have decent exposure, you can do it. MCH, on the other hand, do think very hard before taking up MCH, especially in a place where you're going to pay a hell lot of money to get inside. That does not work practically. I am, in fact, to be very honest with all of you guys, I'm planning for a session for final years who are going to go out and start your practice on how to manage money. Personal finances as a doctor is very important. I learned a lot during the times of COVID, and I just want to pass on the knowledge to all of you guys. So I'll probably do it in one of the sessions, which I think is important. But then I'll tell you, if you have the money, you can arrange for about 40-50 lakhs, and say get the 40-50 lakhs, put it in a there are so many things which you can invest in, and then start preparing for the next exam or get into some other course also. That is far more easier for you to do rather than paying a huge chunk of money just to do an MCH. It is simply not worth it, because all said and done, at the end of the day, it's okay. Suppose you have a lot of money and you don't care about the money. Let's say your lad is loaded and you have a lot of money, you are running a hospital already. The money really doesn't matter. You absolutely need the degree for such a kind of person. It's completely okay. So let's say somebody's parents are already owning a hospital, they are running a cancer center or cancer unit, and for them paying the 50 lakhs or that 1 crore doesn't matter, then yes, you can go ahead and you can do it. But if you are, on the other hand, a first or a second generation doctor who is just starting his practice and you have to just earn based on this practice, this is your primary source of income, you do not have any backup and all this, please do not take up a costly MCH in a private sector. Vaidehi, I know for a fact, is a great institute, but I think the fees is too high there. Whether it is worth getting there, absolutely no clue. I don't have any clue. This is a decision which financially you will have to take. I wouldn't recommend it if the fees is going to be too high. So what is the cutoff for how much money you can spend on your MCH course? I would probably say somewhere around 30 lakhs or 40 lakhs is the maximum you can think through the course that you can put money in there, and you can put as fees and everything, and you can come. Otherwise, whether spending more is worth it, I personally do not feel it is worth spending more than that. Across the board, many places have now increased the fees. So around 20-25 lakhs is coming in many places, even in good institutes, in basic institutes as well. So that is why I'm having that cutoff as around 30-40 lakhs as the maximum. Beyond that, if you want to invest and get it, I mean, unless it's a great institute, don't do that. Yenapoya is a perfect institute. It's a Pakka institute. Dr. Vijay Kumar is heading the institute there. You have exposure to everything, hands-on to a decent extent. You have a skill lab, you have a robotics lab, you have everything. Basically, Yenapoya, as far as a center is concerned, it's not a problem. Though I'm not very sure with regard to what is going to happen with regard to the the fee structure there. So that, have a look at it. But as a center, Yenapoya is a great center, no doubt about it at all. You can straight away take it up. It's not a problem at all. Now, Aurobindo also, I've heard good names. It's one of the better centers. Aurobindo, I've heard generally it's a great place to work, so that is going to be good as well. Mahatma Gandhi Jaipur is again a decent sector where you can reasonable number of cases get done, so that is going to be okay. DNB in Hyderabad corporates, can you just let me know the list of hospitals? I will probably be able to give a, it depends on where you're basically doing. Rather than saying blindly as Hyderabad whether we can do or not, that is going to be a little difficult for me to say. For example, Nizams is a great center. Yashoda, I believe, has got a very good exposure, no doubt about it at all. Indo-American, hands down, you can take it. I'm sure that it will be available for everybody. Whoever is in the top few ranks, it will be gone. Actually, I don't think it will be available beyond that. So number of seats being 24 seats, yes, that is the issue which I told about already, because you have too many seats. There are about 70-75 residents at one single point of time, and for the HOD to remember everybody's name itself is going to be tough. 100 PGs at a single point of time, changing every once in 2 years, is tough. So I'm not sure that is the way, but then still I will say Tata is Tata. So you go there, you will have enough number of cases to do, to learn. They promote their alumni, they send them cases, they refer them cases in the periphery. You learn a lot, you can come out as a finished product. You will have a 1 year bond, and again, if I have a bond, should I take it or should I break it? Always do the bond and come wherever it is feasible. Don't think about breaking the bond. 1 year bond, especially if it's there, don't think of it at all. You will come out with more experience. It is always helpful. The second year, try, if there is a 2 year bond, try to get into one of the fields of specializations that you want to do. And even if you don't have a bond, try to go outside for some international fellowship or something like that. Do it and then come, rather than thinking, for all of you, I will say, think of this as a 5 year course. Rather than thinking it of it 3-year course, think of it as a 5-year course, because many places will have a 1-year bond minimum. And again, when you think about it, many of the people will also in the coming years, especially if you want to settle in an urban metro kind of hardcore metro like heart of Chennai or heart of Mumbai or heart of Bangalore or something like that, they're coming out with an extra specialization at that particular point is easy, rather than to start your practice and then to go outside and start a specialization. Like for example, I want to do something, I want to go and have some outside experience with regard to HIPEC with Sugar Baker sir, or with with Yonimura or somebody. I find it very difficult to leave my practice and go now. It is a tough choice to make at this point of time. Whereas if I had done it about 6-7 years back, when just a couple of years into my practice, it would have been easy. The earliest time is actually 10 years back when I finished. At that time, right then, I should have gone and done, and I should have come back. So the first couple of years after you finish your degree is the best time to get a specialization or a specialty training also, and then to come. So have it in mind, and remember where to go. Don't go by the other factors unless those are very overriding. Some of you, especially for the ladies who are attending this, I will say the personal preferences will depend a lot on whether you're going to be married or are about to be get married, whether you have children, whether your husband is working in the similar area. So all these are things which will make a difference for all of you, because it is really tough. As a girl, it is difficult to work. There is no doubt, especially in a surgical field. And this one, it's got nothing to do with gender discrimination. I am talking about it from a practical point of view, that you may face difficulty. So only in those cases you consider that. Even there, if your spouse and your in-laws or your parents are supportive, get it at the best place possible. Leave the city and go. That is what I would say. Go. Suppose you are living in in Kashmir, and you want to come down to south and you want to learn, come down to south and you learn. If that is the best institute which is available, let's say I talked about Tangam is the only good center which is available to you at your rank, come to Tangam and learn, because that gives you the best chance for learning. This is the final structured program that you're going to run in your life. You're not going to go for a formal training beyond this. All this, whatever is going to happen, is fellowships or some kind of observership or whatever you may learn to upskill yourself. But the major training happens in these 3 years to 4 years which you're going to spend at that institute. So this one you choose with care and get into a good place as much as possible. That is what I would say. Kokila being a developing institute, I'm sure that caseload will be good there, but as like any other institute, you will not have a great hands-on, or the same thing which I talked about in Apollo Chennai. Of course, Apollo Chennai has a lot more experience in terms of the faculty who are there, who are all interested in teaching and all that. So the program is a lot more structured. Kokilaben will be like a private sector hospital where you will just do cases and not do cases. You will help in or assist in cases. Pros and cons of Tata Mumbai. Pros, very easy. It's probably the best national center currently available. You have organ-specific oncology. Every subsite is available there. You have robotics and laparoscopic work. High-end laparoscopic and robotic work is happening. Academics are very good at Tata, because if you're reasonably interested, then you can do a lot of publications, trials. You can be involved in them. You can continue. And being an alumnus of Tata is something like a patina. You say Tata, I'm from Tata, then that's like a chapa on your this one. If somebody says I've done something from AIMS, it's like that. Doesn't matter. Even if it's a Dabba course, they will still say I've done it from AIMS. That makes a difference when you go out for even your employment. So the same way Tata is there, right up there with everything. Even if you are having 100 PGs or 100 PGs all put together, including other MCH and Gynae and everything put together, you may have 80 to 100 PGs, but still it will have its value. That is all the pros that I can say with regard to Tata. Another thing is they value their alumni. They send patients to their alumni. Suppose you are living in some center, they will just call up and say, like, or they will tell the patient, you go there and you get operated. Even within Maharashtra, suppose somebody is in Nasik, they will say, okay, this guy is in Nasik, he's our banda hai, jao aur karke aa jao. Like, you go and do it there. That person is known to us. He will take care of things. So that if a person from Tata tells it to a patient, then they are going happily and they can get it done there. So those are the major pros, and they are running a lot of programs and they are starting their own guidelines. So these are some things which they are doing excellently well as far as Tata Mumbai is concerned, and they have the largest network in India among the people. And among the second list, the same reasons I will say is Adyar is good for many of the same reasons. But the problems with Adyar are there, the value of alumni is going to be a little less. They don't as actively promote their alumni as Tata Mumbai does. But still, I would say it is among the places where you want to learn organ specific oncology. That is the best place you can go to after Tata currently, because all other places do not have, only very few places like Kidway or GCRA, they have a pretty good program of running. But then, exposure to gynae oncology is less in both these places, whereas in Adyar it is pretty good. And I will say, we all know that many of you would have heard that the cutting is a little less at Adyar. It is true, when compared to other institutes it's a little less, but then the exposure takes it far higher than that. And I can say that whatever I am today is all because of what I did at Adyar. And whatever I learned in MS, everything, the concepts turned on its head when I came to Adyar, and that is something too good. So if you have had a decent degree of exposure in your MS, don't bother, straight get into Adyar and don't think about it at all. Many of you are asking questions about language, whether that is going to be a problem when you move from north of India to south, or south of India to north. Don't bother about these silly things. Anywhere where you go, 3 to 4 months maximum, you will learn the local language. Let it be Gujarati, let it be Bengali, let it be whatever be the language, Parsi, whatever is there, you will learn the local language because you will have to communicate to the patients. So that is not going to matter at all. These are all very flimsy reasons to leave a course at a good institute. So don't think about all these reasons for taking up a course or to leave a course. You may find an initial struggle to communicate and all that, but you will pick it up. It's not a difficult thing. I know, in fact, at Adyar, almost every year you will get one alumni who's going to be from the real Hindi speaking belt or whatever. And even as a native of Chennai, for me, almost 30-40 patients of percentage of patients who came are Telugu patients. So I learned Telugu completely only at Adyar Cancer Institute. So it is not like because I am a guy who's in Tamil Nadu, it is easier. No, it doesn't work like that. And that is true for even other places as well, where you will have a good this one. So St. John's, Vaidevi, MS Ramaya, Jawaharlal Nehru. I mean, see, this order thing is a little difficult for me to say because I don't know the fee structure in many of these places. So assuming the fee structure doesn't bother you, I will say that probably MS Ramaya and Vaidehi are right up there. And even for that matter, St. John's is a pretty good place because in general surgery, I heard that, I heard, not rather, I heard, I know of people in faculty there who are pretty good as far as St. John's is concerned. And the same thing trickles down to surgical oncology from what I have heard. Belgaum, I'm not sure. I'm not directly heard about it. So sorry, I cannot comment upon that. But these three institutes, probably I will mark it as, St. John's is first, MS Ramaya second, and third is Vaidehi, just because I think Vaidehi, the cost is pretty high, if I'm not wrong. And MS Ramaya in general has a good program, and they have a wet lab, they have a dry lab, everything, simulation, lot of cadaveric labs, everything is available at MS Ramaya, which makes it a premier institute. Okay. So Osmania versus Homi Baba, it's a little tough choice. Osmania is like your general hospital where you have a lot of unstructured cutting. Actually, I find pretty surprising that a lot of people are asking regarding Osmania. I will tell you that Osmania is a place which fits in with many of the other centers where you have an excellent exposure, but the problem is the cutting is going to be unstructured, unsupervised. You're going to just learn on your own. Of course, in today's world, it is far more easier because you've got a lot of YouTube videos and things like that where you can pick up points. But I still prefer that, all of you know that surgery is something which is taught at the operation theater by the, at the side of the patient, not really always from a YouTube video. If you're already doing it, you can fine tune yourself. But then structured learning is always better. That said, Osmania is going to be there if you do not get a structured learning center. That will be a pretty good one. Homi Baba again will be similar. Within the two, I don't know whether there is anything big to choose because Homi Baba is of course a recent center which has come up. Kokilabin I already answered. Okay, MMC Euro and DNB Onco, what is your opinion? See, here again I would just put it as urology is a pretty good course as far as MMC is concerned. You do endourology, you do a lot of things and all that. DNB Onco in a great institute, if it's available, then I think it boils down to your choice of specialty. And again, I will tell you the same thing. Do not think of specialties as Euro is the top one is gastro, next is onco, next is neurosurgery is there, vascular, endocrine, pediatric, plastic. Take away this mindset. There is work for everybody. Of course, some fields you have a lot of courses available, so there you will have a lot more competition. But that said, think again about unique specialties where the work is only done by another person in that particular specialty. Like I already told you, neurosurgery, endourology, vascular surgery, these are things which can be done only by those particular, in plastic surgery with microvascular or reimplantation work and things like that. I'm not talking about skin grafts or a local flap or something. The high-end plastic work is only done by the plastic surgeon. It cannot be done by others. So these things are actually far more specialized and only those persons can do it, and you have a lot of control over that. Your only competition is going to be another one of your MCH or your DRNB colleagues and not really other specialties. See, gastro and onco, they are top specialties, no doubt about it. But then remember, there is also a lot of overplay and general surgeons. Let's say a patient has got a straightforward cancer of the colon, then it can be done by a general surgeon. It can be done by the minimally invasive surgeon. There is an MCH course in minimally invasive surgery which is available. It can be done by a surgical gastroenterologist. It can be done by a surgical oncologist. It can be done by a bariatric surgeon. For all that, he has the skill and somebody goes to him, he will do that. So it is like, it is going to be shared by 5 different specialties. So that is a tough thing always for you. You have to remember that. So on the other hand, urology, endourology, stone disease, nobody is going to do a TRP or a, whatever, your removal of the stone or whatever, dormia basketing, all that is going to be done only by a urologist. It cannot be done by others. SDH evacuation, it's only a neurosurgeon who can do. In an emergency, maybe a surgeon may be handling it, but by and large, outside in private practice, it's going to be only another, surgeon, neurosurgeon who is going to do. So these are niche specialty. Think about those also. So any specialty, I will think why you are thinking to take up that specialty is something only you as a person can answer that. We can answer about various things. We can help you out. Would you choose oncology? If somebody asks me this question now, knowing all the current scenarios and everything, will you choose surgical oncology? My answer is still going to be yes. If that answers your questions for many of you who are trying to get into oncology, what are the things I would do differently if I choose surgical oncology now? Nothing much. I would still choose, Tata or Adyar as the top options, no doubt about it. And once I finish, the only thing I will probably do now is get some more exposure in the particular fields. I will do my bond period for 1 year, which I didn't do at Adyar. I came out a little early. Now I feel I should have probably done it. And I had my reasons for doing it at that time. But still, now I think if I would have done it differently, I would have continued the bond. And the other thing that I would have done is I would have probably gone for some kind of specialty training at that point. At that time, substrate specific was not even there. But right now, I would probably go for a substrate specific oncology and then I will come out. So these are the only things I will do differently in the current era. But still, there is a lot of scope for surgical oncology. So don't worry about that. GCRI GCRI is a great institute. Basic cases, everything you get the exposure. The problem, what I heard, is you don't get too much of gynae work. Gynae work is a little restricted as far as GCRI is concerned. There is a very little exposure. But then that said, if you're doing a lot of pelvic work in terms of rectums, then doing a gynae procedure is not that very difficult, I'll tell you. So GCRI is a great place. The only problem I have with GCRI is there is no organ specific oncology. See, when you're going for your training, it is better to go for uh, something like a organ specific oncology, because you will get the best of the field from that. On the other hand, if you are going for practice, get into an institute where you can do everything. That will be more better. Of course, you can choose your own field and try to specialize in that as well. Both of the options will be available to you. GCRA onco versus DNB gastro, I mean, that is a choice only you will have to make with regard to which field you like the most. Okay, so GCRA onco is still the top place. There is no doubt about it. In terms of exposure or skills or whatever, it is probably the third largest in terms. I mean, you will take it as Tata, Adyar, then you will have Kidwai and GCRA, which will come up, and there are a lot of alumni coming from these two places as well. So these two are pretty good, pretty high up in the list. So GCRA onco, if you want to do onco surgery, then definitely do it at GCRA. No doubt about that. Whether if you already have your first choice as gastro, then you decide between this and that. That is where the choice will come with you. Adyar, I already told you. See, Adyar has got a great exposure in subsite specific oncology. All the particular subsites are available in Adyar Cancer Institute. Okay, so you take it as head and neck. If you want to talk about particular departments, breast and gynec is a great department. You will get hands-on quite a bit as far as head and neck. I mean, as far as breast and gynec is concerned, you will be basically kind of like running the show. If you're smart enough, you can post the cases which will come to you and everything, and you will have a pretty good hands-on. My major chunk of surgical work which happened in Adyar was in breast and gynae departments. Then when you look at head and neck is headed by one of the alumnus of Tata, and he will not really tell you to, acha, ye tumhara case hai. This one is something that you do completely from start to finish. You do the neck dissection, the tongue resection, and all that. He will not tell you. If when you get to the level, you will be rotated amongst the various departments, so you will be posted in that department. At that time, if you are the final year PG, you are starting the case. Before the consultant comes, you will be having around 1.5 hours or 2 hours. By that time, if you are able to finish the case also, he'll be happy. For him, it is a time bound thing. So if you're able to finish the case at that time, he'll be very happy. Okay, I've done it. Okay, he will just come check everything and then he will go. So it is up to you to make the best use of head and neck. Okay, so that is one. And GIT, the chances are going to be a little less, but then working with Ramakrishnan sir is a great pleasure. Dr. A sir is one of the, it's like if there is an equivalent of a robot in a surgeon, I would say it is actually Dr. Ramakrishnan. He's a guy who deserves high praise because he will follow the same steps again and again and again. You go for a gastrectomy with him for 3 or 4 cases, that's it. Your gastrectomy, you can forget all other gastrectomies you have ever learned or you will ever need to do. He will follow the same steps in a same fashion again and again and again, and he will do it so well, so meticulously. You just need to observe him being on the other side of the table and learn. That is what I did, and I don't feel the necessity for for the fact I did probably, one total colectomy and one LAR or something only is what I had done when I had my GI posting, because we had a change of pattern and all that in the postings and everything. A lot of things happened. So ours was the worst affected batch, and mine was GIT posting was shot to hell because of that. But in spite of that, in my first year and second year, whatever I assisted him in terms of cases, that went a long way, and it still does. You just need to think about how Dr. ASR will do this case, and if you do that, that is going to be very, very good for you. That is going to be an excellent thing for you as far as exposure goes. So, and everything gets done there. Lab work is excellent. He has got great hands. He does minimally invasive. He does robotic. He has started doing now. He does HIPEX. So exposure is going to be pretty high up there for you. And next department is going to be your musculoskeletal and uro-oncology. Now, most places do not have uro-oncology high up in the list, but you do have uro-oncology, which is headed by a surgical oncologist. And again, musculoskeletal also is headed by a surgical oncologist in Adyar Cancer Institute. So that one is a pretty good center for learning the overall exposure, the principles, all that is right up there. Now, studies and publications are recently they have started to increase, and I think it will go up more and more. You have exposure, very good exposure to minimally invasive and to and to robotic oncology also, which is increasing now. So don't worry about that. That's a great center. MS Ramaiah already said basic exposure is good. You have pretty decent exposure. So if the fees is not a big concern, I believe you can take up MCH at MS Ramaiah. Roypeta again is a great center, but here you do not have organ specific oncology, something like the model of GCRI or like KidVai, where you have enough exposure to all cases, including bone and soft tissue. They do a lot of limb salvage surgeries at Roypeta also. So that's a great place. And minimally invasive, currently with Dr. Subbaya being there, he stresses a lot of focus on minimally invasive surgery. So exposure to laparoscopic oncology is very, very good as far as Roypeta is currently concerned. Kokila Bain, I already said I don't have a lot of clue. Saroj Gupte Cancer Center, recently they started their DNB. I think it has now become MCH. I'm not sure whether it's still DNB or MCH, but it's a great center. It's a basic center. Basic learning, you can learn pretty much everything as far as Calcutta is concerned. The same goes for IPG MER also, if I'm not wrong. Both these places, the basic cases, open surgeries, all this get done. Saroj Gupte recently they have started doing lab cases as well. So it will grow up. It is one of the older centers which is there. So don't worry about it in this one. IPG MER also I've told you. KMC Manipal. Manipal in general is good for caseload and for exposure and everything. So generally it is okay to take up Manipal. Himalayan Institute Dehradun is a great place. I think I have it somewhere here in the this one as well. I remember talking about it last year, and one of the postgraduates who had done it there also sent me a kind of like what you say as a institute specific thing. That was a great place. Everything is pretty good as far as the Himalayan Institute at Dehradun is concerned. So yes, you can take up Himalayan without thinking too much about it. HCD Ahmedabad, I have already answered clearly that yes, it is one of the premier centers for oncology. It will be like a corporate oncology setup. So be prepared for a lot of learning as a first assistant. As hands-on, it will be less, but then exposure is going to be pretty good. Now, Action, I believe it is again a good center. It's a decent center. I remember discussing somebody with recently, though I have not actually updated it in the file here. I think Action is a decent center that you can have with regard to this one. KGMC versus RCC, I would probably choose RCC over KGMC because RCC is a great center. I've been there personally. I worked at RCC. I know for a fact that you have subsite specific oncology there. You have GIT, you have thoracic. I'm sorry, not thoracic. You have GIT, you have head and neck, you've got gynae. All this is pretty good there. Very, very good departments there. PGs, the faculty are all nice people there. Of course, the only thing is here again, you'll have to learn Malayalam when you go there because many patients are from Kerala there. Little bit of Tamil patients will come, but then it's a great exposure. All cases are good, and you will get a good hands-on in RCC, no doubt about that. KGMC also has got a good hands-on, but I think because it is subsite specific, I would prefer RCC over KGMC just for that particular reason. And Dr. Madhumurli and others are interested in a lot of lab and HIPEC and those kind of work, so that will be more of a growing center. But that said, I think Dr. Sandeep is there at KGMC who does an excellent work. He's also a great surgeon. It's a subtle difference. I would probably choose RCC just for the fact that it is a better center with regard to subsite specific oncology. That is the only reason. Mahatma Gandhi versus Nizam, tough call. Both of them are pretty similar as far as most of the places are concerned. So it is a toss up. You just look at the thing which I have made, I think. But Mahatma Gandhi right now has got minimally invasive also, if I'm not wrong. Just check it up. I'm not sure. Yes, laparoscopy and VATS is also there. So for that reason, I would probably say Mahatma Gandhi is better. Nizam doesn't have laparoscopy exposure. I put it up in the chart. Okay. And then you have Mahatma Gandhi Jaipur and NIMS Rajasthan. See, MG Jaipur, I've heard good views. NIMS is a recent center, but I think that is also pretty good, and it will be pretty okay for you. First batch DNB, it is a tough call to make, but then look at who is the faculty there. At any place you have to look at the faculty. For example, in the recent INASS, I know for a fact that AIIMS Rishikesh was a great center for working, but then the faculty moved out and another faculty had just moved in last year. So there, the work which was getting done was getting diluted a huge extent. So we all know that INIs generally have a good thing, and AIIMS name itself is good, but then the problem that happens is sometimes when you get into a seat, just look at the institute. In fact, my friends, if you have a very high chance of getting somewhere like this, go personally there and find out, spend a couple of days and find out regarding the institute there and then tell. That is what will be the better thing. SMS Jaipur, I already answered, is a good place for all of you to work. It's not, SMS is a great center overall for this one. So all the basic cuttings are going to be good. And again, remember, my friends, this is something that many people keep asking time and again. Is the cutting going to be good? How much of exposure? At the time when I started doing my surgical oncology, and many of us who have finished surgical oncology about 10, 12 years back or something like that, we had totally about 15, 20 seats across India, which was available for everybody. That is all was there. And we used to take, because that was all the number of seats which were available in MCH or DNB across the entire length and breadth of India. We used to just take it up, go on good faith, learn, and then come out, because ultimately we have to remember that the hands-on may not be that great, but the experience, what you learn, you have to come out and you have to apply it. And there are a lot of other soft skills which are important, which is going to be going far in your life. It is not just about getting a seat in a, even a person who has done it at Tata can still come out without having too much of, too much to say for it. I know people like that from Tata. I know people like that from Adyar who don't really do great as well. So it is ultimately up to the candidate to make the most of whichever seat they do. So I can tell you that these are the things that you need to look for. That I can definitely tell you. And beyond that, it is up to us individually to learn. And again, do not go by only the course. Also think about why you want to do any particular course. I'm talking about everything, even gastro people. It's the number one course. In fact, this time in many of the interviews that I had, top four people that we interviewed among the candidates that we had trained, we found that none of them wanted to do gastro, which was a surprise for me. Usually it will be, two or three out of the top five will be wanting gastro, but here it was different. Any of them wanted onco or urology or other things were there, because people are moving away from gastro. That is what I felt. It is still gastro is the number one field, but then there is a definite shift in the things that are going to happen. So it is not an all or none thing. Whatever we are talking about here is just a guideline to help you select the things. This messages and this power and this thing, I've already put it up in the group. I will just give permission for everybody and all of you. One request from all of you is to please update the list as well, because this is last year's list and I really didn't find the time this year because of a lot of heavy work at the hospital to call up, because this involves talking to a lot of people. For each institute you have to talk to two or three different people to get information regarding that place. So my request is, please add to the institute even one word or something that you get and you add in the PowerPoint. I mean, in the file that I put up in the Google Drive is going to help each and every one of you. Don't think that if you add to it, you're going to lose out. Somebody else will take the seat. It's always going to be helpful. Like Dane Dane pe likha hai, khane wale ka naam. Everybody will get what is due to them. Nobody can prevent that from happening, and nobody can stop you from reaching your full potential. So don't be disheartened also if you get a seat where your hands-on is not great, or your academics are not good, or the principles are not good. These are all, everything is taken together. It's not like you will hardly ever get a place where everything works very well. For example, when I was in Adyar, at the same time, my colleague who was doing an SR ship there, and then he went, because he didn't get at Adyar, he went to Tata. He still came back and he told me, this is a time when you remember there are hardly two seats in Tata. At that time, he came back and he told me that Adyar is a much better place, though the cutting there is much better in Tata. I would say the principles are much better at Adyar, was the words that he told me when he was in his final year. I met him at a conference, at one of the ISO conferences. I met him and he told me very clearly that I would still have preferred to do it in Adyar. I didn't get it. I wish I had gotten it. No, I would have probably exchanged it with him without thinking for a bit. But then he said, you're much better off, because, there are things which are bad at Adyar, but then there are equally good things which we do not realize when we are there. When I went there, I realized it. So nothing is an all or none thing. So that is what you have to look at. Somebody has asked if the faculty is top tier, but hands-on is not guaranteed in the first batch. See, there I will say you decide based on what is the hands-on you have had in your MS. So suppose you have had a good exposure in your MS, you have done all your basic cases, your skills are reasonably good, you know the dissection principles and everything. Then if you have a top tier faculty, definitely go with them, because working with top tier faculty, you learn so many things. See, remember my friends, I am again telling you, see, working as a first assistant to a good faculty is probably one of the best things that you can learn, because you know you learn so much in a very very subtle fashion without even realizing it. I know firsthand what I'm talking about. I didn't realize it when I was doing my MCH. When I finished my MCH, or you know, there's a story which I would have told you, for many of you who may have attended your classes, you know, first year I used to attend, I would go with Dr. Ramakrishnan for assisting in a lot of stomach cases like gastrectomies. You know, we used to do the third layer omentectomy. If for those of you who are not familiar, we have to peel off the third layer of the omentum from the transverse mesocolon. You have to take it. You know that I've read it in NIHUS, but the first time it came alive in front of me was the first case. The first case which I assisted with Dr. Ramakrishnan was an omentectomy, was a gastrectomy where I had to hold the colon taut, the transverse colon, and he went on dissecting the omentum in the third layer. That's when it was like a eureka bulb moment for me to say, okay, fine, this is what you're talking about when you talk about a third layer dissection. Uske pehle, when I was reading NIHUS, I felt like, yeah, what is he saying? He's just blabbering something. I'm not able to understand. Third layer, this layer, anatomical plane, etc., etc. That was my feeling. Where it came useful, I didn't do a single case where I have done the resection in my first year, or even in my final year. I didn't do a single case of gastrectomy. I've done colectomies, but unfortunately, I didn't get a chance to do a gastrectomy when I was doing my MCH. What actually happened was, I was finishing with my gynae postings in second year. At that time, we had a patient who required a total omentectomy, where it was very similar. It was basically the entire omentum was plastered and it was stuck to the transverse mesocolon. So the plane was only available in the third layer. So I just went ahead. There was another gynecologist. He's not a gynecologist. There was only another gynecologist, pretty decent person. So I said, ma'am, you just help me out, hold it like this, we'll do it. And I just managed to finish it. You know, that's when I felt, okay, so this is what you're learning. You never realize what you're learning till you actually do it. And that is what I realized at that point of time, that is very, very important to work with people who are kind of having a good hands on and who have a particular technique. You just have to pick up that technique. If you do that, you will always learn. So don't, even if you get an okay institute, don't bother about it. Okay, first thing, ask yourself whether you want to do this particular branch. Am I okay doing surgical oncology, and why I want to do it? Have it clear in your head. If you are sure regarding that, then take up at the best rank what is available to you, take it up and go there. In that place, whatever is the best thing possible, you learn and then you start doing it. Okay, you may get a few hands on, you may not get hands on, you may get to assist, you may get to watch laparoscopy, robotic, whatever is there, learn from each and everything. Whenever you go for cases, read regarding the case and go and read regarding the surgical part of the case. Nowadays you have a lot of YouTube videos which were not there at all when we were doing our MCH and all that. Now it is anything you want, the procedure is there on YouTube. You can just watch the video. And again, remember, this is more like a penance. I know that it is tough, but remember, this is like a penance that you have to do at the time when you're doing your, uh, you know, any course that you're doing. This is going to be the last 3 years of finance that you're going to do. So in this finance, what you need to do is you have to learn, make every opportunity, make use of it to learn. And places may be a little toxic, maybe a little less toxic. All this is going to be there, but then learn, keep learning. So that is what I want all of you to do. And if you do that, I'm pretty sure that all of you will come out happy with the course that you're doing. Inside this, you will have variations, good, bad, everything, ugly also in some cases, but then get to do it. It will be good. So all the best, my friends, in choosing this. Tomorrow is the last day. This link I have shared in various groups, so kindly circulate it in the other groups. Those who do not have it, I will give the permission maximum by tomorrow morning for everybody to access the file, because I don't know really how to share without this one. It allowed me the option of sharing only with this one, to to share the file with permissions only. So tonight till midnight I'll be doing the permission sharing, and tomorrow morning also I'll do it. So by tomorrow evening you can look at the file and you can all mark your choices and fill it up. Okay, so all the best all of you, and do well, my friends. Do not worry about things, and remember, always there are other things in life far more than getting a good seat or a good college or whatever it is. There are so many other things which are going to be there in life, so don't get bogged down by these simple things which are going to happen here. uh, Among the choices, take the best available one and please go ahead with that. And again, wishing you all the very best in your course and in your future as well. Thank you, my friends. I think there are no more questions here. It's no, I'm not seeing any more questions in the Q&A box. So I hope that everything is answered. Most of you got the answers to all your questions. So I'm winding up the session here, my friends. Thank you and all the best. I'm still online here. If you have any more questions, you can post it here. I'm still online here. So if others, anybody who has any kind of question, please, my personal choice. I mean, this is a very difficult question to answer. Depending on what is your rank, ultimately it will boil down to your rank. No? But as I said, the top four institutes will be probably I'll start off with Tata, then it will be Adyar, and then Kidwai, GCRA. Depending on where I am staying, if it is south, I will probably choose Kidwai first. Otherwise, I'll choose GCRA among the two. So these two will be there. Then there is RCC Trivandrum, which is a great institute in the south that I know of. In the north again, KGMC is a great place. DRNB at Indo-American and at Rajiv Gandhi. DRNB, which is currently running at MBR, at Malabar, at Silchar, Kachar Cancer Center. So these are some centers which are pretty good that I know of. So Rajiv Gandhi versus Indo-American. Tough choice. Rajiv Gandhi, I believe, you get a little more hands-on. Indo-American, on the other hand, you get a little more hands-on with regard to lab work. So you will have to choose between the two where you are going to do. But Indo-American overall, I would choose probably first. So Indo-American first, and then it will be Rajiv Gandhi probably. Adyar versus Indo-American, I would still say Adyar and then Indo-American because Adyar has got a greater number of alumni and you have got a more organ-specific approach. Indo-American will be, though it is a close choice, it is kind of like very tough to make a choice. Aster, yes, I will take it. It's with Dr. Somashekar, so you can definitely take it. Indo-American, Rajiv Gandhi, I just answered. Kidwai RCC, probably my choice will be towards RCC because it is organ specific, but then Kidwai is an equally good option. So more subdivisions in oncology. See, you never know how the MCA or anybody will take it forward. There is a lot of policy making and decisions and everything which goes on there. So it's a tough call to make with regard to how things will pan out in the future. My thing is don't keep thinking about the future too much. You just focus on the present and to a reasonable extent you'll be all right. I'm sure there is a lot of work in whichever field you do in surgical oncology. In case there is more subdivisions, just train yourself a little more in that field. That's why I said think of it as a 5-year course. Get into one of the subsides once you finish and do a little more work there. SRMC Chennai is a great place for having a good exposure, but hands-on will be limited. Professor JC Bose is heading the unit, and academics and exposure will be paka. Lab work is also happening. Dr. Bala is there, who's taking care of thoracic a little bit. So a lot of good caseload and everything will be there, but hands-on is likely to be limited. You will get a little bit also, though it is not going to be this one. NIMS, Indo-American, Apollo Chennai, Tangam and Malabar. It will be Tangam and Malabar in the top two places, closely followed by, sorry, Indo-American is there. Sorry, Indo-American will be the first. And then you will have Tangam and Malabar. Then you will have NIMS and Apollo as the order of preference that I would say. Better to be organ specific, yes, better to be organ specific in your training. In your basic training, it is better to be organ specific because you will learn more. And when you come out, whether to be organ specific or not, you learn it and then you come. But this again depends on the place that you want to practice finally. Suppose you are already in a tier 2 city where there are not too many surgical oncologists, straight away start a practice and then you will be well set by the time anybody else starts a subspecialty practice. So there it will not matter. But if you're going to a top tier city, then yes, it is better to be organ specific, going by the current trend. Even though it is not absolute, there is still a lot of value for surgical oncology in the cities as well. But then it is better to train yourself for the future and be mentally ready for it, because it's about the policy makers and none of them are ready to take a stand against it. So that is the problem, I would say, though I'm not too much in favor of it. You have to go with the flow. That is the way I will put it. Kidwai versus RCC, as I already said, RCC probably just slightly edging out Kidwai because it is organ specific, but otherwise Kidwai is the older institute, so it is just a slight difference. Kidwai cutting versus DNB, DRNB cutting in Rajiv Gandhi. Overall, probably Kidwai will be better. Rajiv Gandhi is of course a kind of like DRNB institute, but then it is going to be a close call between the two. SMS versus Max Saket, I would probably choose SMS Jaipur first. Urology. Oh, Urology also, I think it will be, you'll have to ask somebody who's doing urology, but then I think generally with SMS, because it's the main government hospital of the place, you will have a lot of exposure. So any government hospital like that, you will have the basic cases down. And there I would probably say it's SMS Jaipur Urology if you're okay with urology. Otherwise, it will be Max Arcade DNB, of course. KMC Manipal versus Aster, tough choice. I would probably say Aster now because Dr. Someshekar, because he's a really dynamic person who does a lot of work and who will make sure that you get a good exposure. Indo-American Osmania, no doubt. Indo-American. Choose Indo-American first, then you choose Osmania because Osmania has a lot of unsupervised cutting that happens. So Indo-American is far better. Kidwai Tata Varanasi versus Rajiv Gandhi. Okay, this is a slightly tougher choice, I would say. See, generally Tatas are good, but that's a new center, so I'll still open my this one. I'll probably put it as top two will be Kidwai and Rajiv Gandhi, depending on which you'd want to take, depending on the place and everything. Second will be your Tata Varanasi. 145 rank available are Kidwai, Adyar, Indo-American, and Rajiv Gandhi. Adyar is not possible because of the fees. Arey Baba, Adyar fees is not so high, it's only around 6-7 lakhs. Don't think about getting a loan, get a loan and get into it. That is what I would say, because whatever you are making, just think that you are paying it for this one, get a loan and get into it. Adyar is better, but if you want absolutely not, you're not able to do, then you have Adyar down the list. In that case, it will be a choice between having, as I said, Indo-American, Rajiv Gandhi and Kidwai is pretty closely matched. Look at all the other factors and then take a call. Kidwai, because it is an MCH, it is one of the oldest institutes, but then Rajiv Gandhi and Indo-American, if you're okay with DRNB, go with that as well. Kim's Hubli versus Aurangabad GMC. I am not very aware of these two institutes, so sorry. That is a difficult question for me to answer. MVR versus Tangam, again closely matched. MVR is run by entirely by alumni from Adyar. It's a perfect place for you to learn all things, including I think they are doing a bit of thoracic work, some bit of limb salvage. I think they have started. Everything gets done. Tangam is also a great center. I think only thing they don't have too much of limb salvage or musculoskeletal is a little less at Tangam. All the rest it's going to be pretty evenly matched. So it is just basically just put MVR on top and then followed by Tangam. But then robotic if you want, then Tangam is a better exposure because robotic gets done routinely at Tangam and thoracic exposure is much more at Tangam. Whereas MVR will be better for GI work, for the rest of the work which gets done for open cases, for oncology. And this will be like doing your MCH only. MVR, when you do, it will be like any government institute where you do your MCH. That is the way it will be working here. So this one I just answered, I think. SMS Jaipur Urology versus Max Arcade is what I said. Urology is better probably if you are okay with the government-based institute, but if you want oncology, straight away the answer is Max Arcade. Surgical gastro or onco and later specialize in GI onco. That is a tough one. See, I would probably say you do surgical oncology and then get into GI oncology as a subspecialty, get your separate training there. That will be a better choice than doing your surgical gastro and getting into it. But here again, it will depend on what is your choice. If you want to have a more widespread approach, do benign cases also. See, the major problem as far as oncology is concerned, I will say, is because you do not have anything in the way of small cases. For the small cases, only a biopsy. That's it. Nothing else. You can do a node biopsy, you can do a small excision or something like that. But by and large, most of our cases, the smallest case which we do is probably an MRM or an egg dissection. So those are all again pretty advanced even for a surgeon. So it is like that kind of thing. So surgical gastro, on the other hand, you can still do appendix, you can still do a straightforward coli, you can do a lap hernia, you can do a hernia, you can do piles, you can do bottom cases, everything you will have. So that way, doing everything together, surgical gastro is a better option just because of that reason. Otherwise, onco, hands down. Indo-American versus NIMS, Indo-American, no doubt about it. No question at all. Indraprastha, Apollo and Tata Calcutta, Tata Calcutta. Tata Calcutta has got an excellent program. They have got pretty much good exposure in everything. So Tata Calcutta triumphs every time over Indraprastha Apollo. Indraprastha is more of a corporate sector thing where you can do it. You will have a decent exposure, but I don't think it's as good as Apollo Chennai. So that will be way down in the list. And GCRI versus Kidwai is a very closely run thing. Both of them have a similar profile and less exposure to gastro with regard to less exposure to gynae oncology, not having organ specific oncology. All these are there. Kidwai will have a slight edge because they now have robotic surgery as well. So robotics is there as Kidwai, which is not there currently at GCRI, I believe. So I think that is the reason. Probably I'll say probably Kidwai and then GCRI. On the other hand, if you are in the northwest of Chennai, northwest of India, where your practice is going to be there, then probably you choose GCRI so that you will have more of contacts and connect in that area. IMS SUM is a good institute from what I believe. It's a decent institute is what I believe. Chengalpat versus SMS Jaipur. Chengalpat, as in Karapetai, will be a great center. They are doing good work in this one. In lot of basic cases and everything will be pretty good. Uh, Lab work and all that is just starting. I believe they will just start in a couple of this one. It will be more structured at Chengalpat because it's a proper cancer center compared to SMS Jaipur. So probably I'll choose Chengalpat over SMS Jaipur. Chittaranjan Calcutta, New Cancer, it's a great center. See, Chittaranjan is probably the oldest cancer center in India. It's like when you look at it, Adyar was the oldest, then closely followed by Tata and Chittaranjan. Those two were the places that have been there for a long time. So no doubt about it. It's like you can definitely think about taking Chittaranjan if it is available. The exposure will be good. Basics and all will be definitely well covered there. Ruby Hall, Pune is again another center where you have a great exposure. It's a private hospital, but they are doing all kinds of cases. It's a great place to work as far as DRNB is concerned. Um, if I could tell about pediatric surgery, I would suggest that you get in touch with Dr. Rahul, who will be able to much better answer this among the faculty. He will be able to tell you much better. I'm not particularly aware. I know that ICH has got a great program. Institute of Child Health in Chennai has got a GACE program, but I don't know about the rest of the institutes as far as pediatric surgery is concerned. So kindly contact Dr. Rahul from the doctoratorials team. He will be able to guide you on that. NIMS versus Tangam. That's a NIMS, I'm hoping it's Nizams, so Nizams Institute of Medical Sciences. So here I would probably say Tangam is better because laparoscopy and robotic work, all that happens as Tangam. Then it will be NIMS. So NCA Nagpur versus Bombay Hospital versus Ruby Hall. Now that is a toughie. I'll tell you though that Bombay Hospital, I have personally gone there. It's a great center. Even then, surgical oncology used to be a field which was doing well there. So surgical oncology at Bombay Hall and at Ruby Hall is pretty good. NCI Nagpur, again, it's a government institute, I believe, so it will be good. It is a close call between the three. I'm sure wherever you do, you will come out pretty much doing well. Tanjavur versus Aurangabad. Tanjavur is a basic center. Whatever you want to do, you will get all that, head and neck, gynae, breast, GIT, all these cases will happen. Aurangabad, I don't have too much of awareness. Okay, so that I'm sorry, I don't know actually. I don't know about, unless I put it up here. Aurangabad. No, I wasn't able to get any connect in Aurangabad. So sorry, I don't know about Aurangabad. I know about Tanjavur. It's going to be a decent this one. Ruby Hall, I already said it's a great center, and this one. Acharya Harihar versus this one. Acharya Harihar is also a good place to do your surgical oncology program. RCC, I think, though, is better because you've got a subsite specific oncology. Again, that is the only reason I would say RCC is better. And overall, you will get more structured learning at RCC. IPGMER, yes, IPGMER is one of the older institutes in Calcutta again. So it's a government-based institute. So, no need to worry about it. So you can take it up. And Harkishan Das, I don't think I have too much of this one there. I'm not sure. Himalayan, I have put it up here. It's all good. Everything is good. LAP is not there. That's the only thing that you don't have as far as the Himalayan Institute. Somebody has asked regarding the Himalayan Institute before. So the answer is generally, as I remember telling before, everything is good except thing is you don't have lab and robotic. That's the only thing which is not so great there. And Indo-American versus Rajiv Gandhi, as I already said, probably a slight edge for Indo-American just because of the faculty there. The only thing you have to remember though is Rajiv Gandhi will have much better robotic opportunities. Robotic gets done a lot more in Rajiv Gandhi. It is a matter of fact, every case gets done there. Indo-American, lot of lab work gets done. Robotic is a little less because they are doing excellent lab work. They don't find the advantage in the robo. And Dr. Subramanieshwar Rao and Dr. KVN Raju, both of them are very great faculty who kind of like they believe in having technology which will be at a lower cost for the masses. So that is the way it works. Harkishan, those I don't have too much of an idea. I'm sorry. And G. Kupuswamy, GKNM is a great center. GKNM is one of the old hospitals in Coimbatore for a very long time. It has been there. Dr. Bhargavi and Dr. Kartikesh are there. They are pretty good as far as GKNM is concerned. I think Dr. Kader is also there, if I'm not wrong. Three people are there. Dr. Bhargavi and Dr. Kartikesh are definitely there. And it's a pretty good basic exposure. You will have a wide exposure, no doubt about it. Lab and other stuff may be a little less, but basic exposure, you can take it, no doubt at all. You will get principles, you will get this one, ethical training, everything will happen there. MMC versus Madurai. See, MMC I will choose here for only one reason because MMC has the Robono. It is associated with the Omandurar Hospital. So they have robotic surgery. It's the first government institute in Tamil Nadu to have the robotic surgery thing which has come in. So that is the reason why I'll choose MMC. But if you take up in terms of faculty, if you take up, in other words, like if you leave robotics out of it, then hands down it is Madurai. Dr. Ramesh is the HOD of the unit, and you have got Dr. Gurumurthy. Uh, it's a very nice unit to work in. Madurai is one of the best places in terms of faculty to work in. Dr. Ramesh is one of the nicest persons. I have known him since the time I did MS. At the time I finished, or I was in my final year in MCH in my surgical oncology posting. At this time when actually Dr. Ramesh came in there after finishing his MCH at Roypeta. He's one of the gentlemen you can get in the field of in surgical field as such, and in surgical oncology particularly. He's a very nice person. He's the HOD and he promotes people. He puts forward his assistants and all that. So as a unit, if you want to work, get exposure to minimally invasive and everything, if that is enough for you, go to Madurai. If you particularly are looking at robotic exposure, then you go to MMC. Aurangabad is basic. Okay, thank you for that. No lab, no protocols, no advanced, no academics. Okay, so fine. I think it is like any other government medical college. Fees at Hamal Sai, I'm sorry, doctor, you will have to look it up in the whichever thing they are publishing. I'm not sure of that, but it's a good center to work in. So that is something that this one. So if you someone wants to practice directly after MCH, should we consider Kidwai or GCRA or Tata? See, here again, I will tell you there are some things which are wrong with Kidwai and GCRA, that is gynae oncology. You don't have a great exposure. So, right after you finish, whether you can do gynae oncology to that extent as you will do at Tata, because the Tata will have a pretty good exposure to gynae oncology. So, still, I will say choose Tata. There's no doubt about it. Still, you choose Tata. Only after that, you consider Kidwai or GCRA. Sadhu Vaswani, no, sorry, I don't have an idea regarding Sadhu Vaswani. MCH Euro versus DNB Onco, it is, it's a very difficult thing to decide. See, because MCH versus DNB, I already told you it's not about DNB, it is about where you are getting the DNB. If you're getting DNB at a good institute, hands down, and you want to do, you like oncology, take up oncology. On the other hand, if you're okay with doing urology, it is something. See, for example, I was always interested only in oncology first and then in gastro. Urology was never in my list at all. But fortunately or unfortunately, at that time used to be a common exam, just like what you're having in NEET now. At Gujarat and Bombay, the pattern used to be common MCH exam. So whichever rank you get, based on that, you can take the seat. I got rank 10 and I got into urology immediately at Bombay Hospital. Just because I got the rank, I took up the seat. But I had a sea change in my thought process in urology after I went into the field. I actually liked urology. The only reason I left the seat at Bombay Hospital was because it was not recognized at that time. But I will still recommend MCH urology at Bombay Hospital for anybody who is willing to take it. It's one of the most excellent courses that we have. You have subsite specialization. This is I'm talking about in 2007. You have people who are doing only transplants, who are doing only pediatric urology, who are doing only uro-oncology, who are doing only endourology. It's gynae, urogynae is another area. So subsite specific used to happen at that point of time. This I'm talking about, 15, 16 years back. At that time, they had subsite specific urology. So if you are getting a good MCH and you're okay to do uro, go ahead and take it. No doubt at all. Should there be a tie-up with medical oncology for practice for surgical oncologists? See, ultimately, we are all interdependent on each other. So it is not that you will need one particular medical oncologist. You will need to tie up with a lot of people. It's not, and usually they will also have a tie-up with many people. Of course, if you handle them well and you are able to have a good relationship with them, they will refer the cases more often to you. Here is where you know how your hands are, how good the work you do, how much of a complication rate you have, how good a relationship you have. All this will matter more when it comes to an actual practice. So whether it is mandatory, no, but you will definitely need medical oncologists and you will get into touch with them at that point of time. Fortis Delhi, let me check. I think I have it here. No, I am sorry, I didn't have any contact in Fortis Shalimar Bagh in Delhi. So sorry, I don't know about this. So surgical oncology future as head and neck and gynae and organ specific have come. Many fellows are there in TMH in every department. At TMH, it is a problem. You will get less number of cases. But as a whole, I still believe there is a lot of role for surgical oncology. That is why I'm keeping on saying do surgical oncology and then you do what is like you do a subsite specialization by the time you come out. That is what I would still say, rather than saying that there is no role for. There is a lot of role for, enough role for surgical oncology, especially in the peripheries and everywhere. You have a lot of role for that, no doubt about that. Okay, Fortis Delhi already said that I don't have contacts there, so sorry, I don't know. So again, my friends, all the best. Don't worry too much about things. Things will fall into place. Uh, I keep hearing this often, and I'm a guy who strongly believes in God. It happens also when there is a door that is closed. Somewhere there will be a window that opens. This is something which is from a movie which I've heard, but then it is very, very true as well. We always find that at the worst possible moments in life, you will get somewhere some ray of hope that comes to us. And all of us have doctors. As doctors, we have all gotten a good exposure. We can all survive, guys. It's not a problem. Don't worry about all this, whether there is a future, whether there is this, that, everything. There will be a future for everything. Don't worry about, mm, having all this. You will, as surgical oncology is still one of the, see, this year is a sea change in surgical oncology. Many people in the top 100 are actually getting into oncology rather than, in the list which I got in the common list in NEET, SS, the specialization, a lot of surgical oncology was there, surprisingly. I thought that was coming down in many of urology and this one and all that. Recording of the video, I have to ask the people from Doctor Tutorials. I think they will be putting it up. Sri Shankara in Bangalore is a decent center. I think there was a very good faculty there. Currently, one second, let me look it up. I had Shankara. Is it an MCH or a DNB program? I think it's a DNB program, right? One second. Karnataka. Yeah, Shankara. No, sorry, I didn't have any direct this one, but I remember someone tell me that Shankara had a good faculty, but currently that faculty has moved out. So that is the only reason I'm not sure about that. So Shankara on the whole is better that way. So it's a DRNV program, but yeah, I think it was a good program. But now that faculty who was in charge has moved out. Till that point of time, it was a good. This one I remember one of the students talking to me and telling me that it is a good program, but the faculty moved out. So I don't know regarding the current status of the DRNB program at Shankara. So sorry guys, sorry I'm not able to help out there. So all the best, my friends. I hope this video and the session has helped you solve many of the doubts with regard to whether to take up oncology or not, what makes you take surgical oncology, how to proceed with it, which institute is good, DNB versus MCH, whether there is a difference. Outside there is nothing. Doesn't matter whether you have DNB or MCH or what, and which field to take and everything. So all the best, my friends, and make your choices well. Finish all the basic work and everything. Do it by that, and then go ahead with it. Do well also. Tomorrow night we'll be having a interview session of INASS. This is only for Dr. Toriel subscribers. So please join whoever has gotten selected for the INASS interview. Please, share your details, and you have to register and all that. There is a lot of processes which is there. Do that and go ahead with that. Okay.